Last class, in our last class, we discussed some of the upper respiratory tract infections, common upper respiratory tract infection, which is in your syllabus, like acute nasopharyngitis, common cold, acute pharyngotonsillitis, and acute otitis media. Now, in today's class, we will discuss some of the upper respiratory tract infection which is in your syllabus. So, today's topic of discussion are Stridor, acute epiglottitis, acute Laryngotracheobronchitis, and foreign body aspiration. Okay. Have you ever heard the name of Stridor? Stridor? Have you ever heard any Stridor? Anybody? This class is not only for your exam purpose, but it will be very effective for your future practice particularly if you become a pediatrician. Okay, so please listen carefully. What is Stridor? Okay, I am going to start with the Stridor. What is Stridor? Stridor is an abnormal high-pitched breath sound which is produced by turbulent airflow. So Stridor is actually a high-pitched sound due to some obstruction in the airway. Okay, where is the obstruction? The obstruction, there is partial obstruction. If the obstruction is total obstruction, there will be no sound. But if the obstruction is partial, you will get a sound, but that sound is not normal. Okay, so it is due to obstruction, partial obstruction at the level of the supraglottis, glottis, subglottis, or trachea. Okay, and what is starter? There is a similar sound. It is often confused clinically, which is known as starter. What is starter? Starter is a snoring-like respiratory noise due to obstruction in either in the nasopharynx or oropharynx. Okay, what are the causes of starter? Choanal atresia, enlarged adenoid or tonsils, and redundant upper airway tissue. So, I can't mimic Stridor, so I am going to make your eyes familiar with these two sounds. I am just trying to make your eyes familiar with the sounds. শোনা যাচ্ছে? What is it? So you don't need any stethoscope to hear Stridor. This is a audible respiratory sound. Okay. So it is Stridor. And what is starter? This is starter. So these are the very much useful in your clinical practice. These, yes, both are audible. Snoring means nagdaka jake bole bangla. Okay, but starter is not nagdaka. It is something from the airway, okay, either glottis, supraglottis, glottis, subglottis, or trachea. Okay. So next is Stridor is classified according to the site of origin, or it is classified either it is congenital or acquired. Okay, which is inspiratory Stridor means Stridor which is predominantly heard during the inspiration, and expiratory means it is heard predominantly in the expiration, and biphasic means the Stridor is heard both during inspiration and expiration. So when the Stridor will mainly audible in the inspiration when it is originating above the glottis. Okay, that is supraglottic structure. When it is arriving from the look at this slide, when the Stridor is coming out from the either thoracic trachea or bronchi, it will be expiratory. But when this structure, these lines, these two lines, this indicates the glottis, subglottis, and cervical trachea. When the Stridor is originating above the glottis, either from the pharynx or supraglottis, it is inspiratory Stridor. That is, the Stridor will be heard. All the Stridor will be heard both during inspiration and expiration, but it is named according to the phase where the stridor is hard based. Okay, in this anomaly, in the pharynx or supraglottis, the stridor will be hard mainly in the inspiration. So it is called inspiratory stridor. And if the stridor is hard mainly during the expiratory phase of the respiration, that means the abnormality is either in the thoracic trachea or bronchi. Okay, trachea is classified either cervical or thoracic. If the obstruction is glottis, subglottis or cervical trachea, then the stridor will be hard both during inspiration and expiration, that is biphasic stridor. Okay, is it clear? So, inspiratory stridor suggests an airway obstruction at or above the level of the vocal cord, and expiratory stridor suggests airway obstruction. Expiratory stridor, that is airway obstruction at the level of the thoracic trachea or at the level of the thoracic trachea or bronchi, and biphasic stridor, I have shown the obstruction is either in the glottis, subglottis or cervical trachea. Okay. So what is the mechanism of developing stridor? Very simple. Actually, the main reason is due to obstruction. Okay. Where is the obstruction? The obstruction may be anywhere. I have shown already. The main difference is the infant or the child's airway lumen is naturally narrower or smaller than the adults. Okay. The diameter of their airway is not similar to us. Okay. Now, if there is any causes, that may be congenital, that may be acquired, where there is obstruction of the airway, you know one formula, that is resistance is proportional to the fourth part of the radius. Okay. So if their airway is narrower, now if the airway becomes more narrower, what will happen? So therefore, any minor reduction to this airway diameter, such as inflammation, mucosal edema or foreign object, or collapsing of the epiglottis, can result in further narrowing of the obstructed airway. Due to narrowing, it causes an exponential increase. What I am talking? Exponential increase in airway resistance, which makes it significantly difficult for the child to breathe in. So these are some congenital causes of the stridor. The most common is, remember, Laryngomalacia. Laryngomalacia is one of the most common cause of congenital stridor. What is Laryngomalacia? It is due to some abnormality of the cartilage. Okay. Yes, either epiglottis or arytenoid, etc. So actually when the child is in supine position, then the structures above the vocal cord, that is supraglottic structure, they usually prolapse. Okay, and causes difficulty in breathing. So it is known as Laryngomalacia, and remember, it is one of the most common cause of congenital stridor in children, followed by vocal cord paralysis. You can see in the second picture. This one is the vocal cord paralysis. Maybe unilateral or maybe bilateral. Unilateral is commoner than bilateral. And third one is the subglottic stenosis. Here you can see that the airway lumen is gradually becoming narrower. So this is subglottic stenosis. It is not possible to discuss all of these in details. Just look at the picture and remember the names. Okay. This is laryngeal cyst. So all of these causing some obstruction and causing stridor. There are few more. That is laryngeal wave. Yes. Yes. I have forgotten to mention. Sayan is very right. Thank you. It is very important. It may come as an MCQ that in Laryngomalacia you may get a epiglottis, what is known as omega septate epiglottis. Okay, omega septate epiglottis. So laryngeal wave, there is a tissue in between the vocal folds, which is causing obstruction and causing the stridor. Vascular anomaly. Well, we all know there is one aortic arch, but when there is double aortic arch, it causes an obstruction of the airway, as both airway or esophagus, just like a pincer. Okay. So this picture. Okay. So this is known as vascular ring, and it is one of the commonest cause of stridor at birth. Remember, at birth. Okay. Cleft larynx. Well, it is also a congenital anomaly where there is some gap behind the larynx, and it causes the food particles to enter into the larynx every time the child is giving feeding. Okay. And this one is lymphangioma, that is some lymphatic obstruction, which is causing obstruction at the airway. Subglottic hemangioma. If you get any type of hemangioma in the body, then you can suspect there may be a subglottic hemangioma behind the stridor. Okay. So these are the some commonest cause of congenital anomaly of the larynx which causes stridor. Stridor may be also due to some acquired causes, paralysis. Congenital causes of laryngomalacia, stridor. They have already told laryngomalacia, vocal cord paralysis, cyst, subglottic stenosis. Very good. Well, acquired causes, it may be due to some trauma, either due to thermal or chemical injury, or it may be iatrogenic due to intubation. It may be inflammatory, like acute epiglottitis, acute laryngotracheobronchitis, retropharyngeal abscess, or diphtheria. It may be due to foreign body also in the larynx, trachea, bronchus, or any external compression from the esophageal foreign body. It may be due to allergy, like angiography, edema of the larynx or trachea. It may be also due to a neoplasm, like juvenile papillomatosis. Okay, so just remember the causes. And this is the summary what is discussed in the last few minutes. Okay, stridor is actually can be classified either due to congenital acquired causes, and congenital causes I have already mentioned all of these, and acquired causes can be also classified either afebrile or febrile. Okay, so move on. So how will you approach to a case of stridor? Either you are just imagine that you are in a clinic or in your OPD and one small baby came to you with this type of sound, that is stridor. Now how will you approach to this child? So remember, stridor is actually a physical sign, it is not a disease. So every attempt should be made to discover the disease, and it is important to elicit the history of onset, effect of position, effect of crying, etc. I have already mentioned that most common cause of congenital stridor is laryngomalacia, but most common cause of stridor at birth is not laryngomalacia. It is either laryngeal wave or vocal cord paralysis. So if you get any stridor at birth, never think of it as laryngomalacia. Any type of malacia, remember, any type of malacia arises few weeks after birth. If it is since birth, the cause is not malacia, it may be a laryngeal wave or any vocal cord paralysis. Okay, but few weeks after birth, you can suspect laryngomalacia. And effect of position. This is also very important point in differentiating the causes of stridor. If the stridor disappears in prone position, it may be the most common cause is laryngomalacia, may be due to micrognathia or macroglossia. Okay, there is a syndrome which is known as Pierre-Robin syndrome, where there is macroglossia, micrognathia, either with or without cleft lip or palate. So in this condition, you will also get stridor. Okay. Effect of crying. If the stridor improves on crying, it is bilateral corneal atresia. Which one? Micrognathia and retrognathia. Look at the slide, just last one. Congenital causes of stridor. You have already learned these. All these were shown in the picture. Laryngomalacia, wave, stenosis, hemangioma, vocal cord paralysis. But this was not shown in the picture. Okay, this was not shown in the. I have mentioned it here. Pierre-Robin syndrome. It is a syndrome. Okay, where there is micrognathia, that is mandible is short. Okay, and macroglossia, large tongue. Okay, with or without cleft lip or palate. And in this condition, you will get stridor. Okay, and what is the characteristic of this stridor? This stridor disappears when the child lies in prone position. Okay, prone position means effect of crying. It improves, then it is bilateral corneal atresia. If worsens, then it is laryngomalacia. Okay, progression. If it is rapidly progressive with drooling, it is acute epiglottitis. We will discuss acute epiglottitis in details in today's class. Gradual progression, ALTB, that is acute acute laryngotracheobronchitis or hemangioma. If fever is associated, then you must think of some infective cause like epiglottitis, ALTB, retropharyngeal abscess or laryngeal diphtheria. If other precipitating factor like if there is a preceding history of choking, then you must think of foreign body aspiration. If it worsens with feeding, then you think of tracheoesophageal fistula, vascular compression or tracheomalacia. So next, coming to the examination of the child, if the child looks very toxic, there must be some infective cause, and the most common is acute epiglottitis or acute laryngotracheobronchitis. But remember that the acute epiglottitis is a bacterial infection. The child looks more toxic. So if toxic child with fever, with stridor, think of acute epiglottitis. If tripod position, decubitus, I will show you what is tripod position looks like. It means the child is suffering from acute epiglottitis. If fever is associated, already mentioned. If there is urticaria edema, then think of angioneurotic edema. If there is any cutaneous hemangioma over any parts of the body, think of subglottic hemangioma. If there is unilateral decreased air entry, foreign body in the ipsilateral bronchus. If there is cyanosis or murmur, think of any type of congenital heart disease. So what are the relevant investigation? Just remember the name of the investigation, X-ray to diagnose any foreign body. If there is any radiolucent foreign body, okay, then the need is to do a fluoroscopy. CT scan to detect mediastinal mass and other congenital vascular anomalies. Angiography may be needed for vascular anomalies before operation, and esophagogram to detect tracheobronchial fistula or aberrant vessel or esophageal atresia. So this is in short how you will approach when you will get a case of stridor. Okay. Next, coming to the second part of this today's class, that acute epiglottitis. So you have heard so many causes of stridor in children, but the commonest causes are, remember, acute epiglottitis, acute laryngotracheobronchitis, retropharyngeal abscess or foreign body aspiration. So now we will discuss three. That is acute epiglottitis, ALTB and foreign body aspiration in today's class, which is in your syllabus. So what is acute epiglottitis? It is an acute inflammation of the subglottic region of the oropharynx with inflammation of the epiglottis, vallecula, arytenoid and aryepiglottic fold. It is a rapidly progressive disease. The most common age of children presenting with this disease is 3 to 6 years. And it is an emergency. Why emergency? Because the time interval from the start of the symptom to total respiratory obstruction is extremely short. So you will have to manage the case very rapidly. Okay. The common organism is the most common culprit is H. influenzae type B. And what are the symptoms? Fever. The child will come with fever, acute onset of sore throat, muffled voice, stridor. And what will be the type of stridor? What will be the type of stridor? Inspiratory stridor, because the disease is above the glottis, supraglottic. So it will present with inspiratory stridor, marked dysphagia, drooling, okay, drooling of saliva, and the child will look very toxic. This is what is known as tripod position. That is, the child will sit with leaning forward with the hands by the side of the body. There may be respiratory distress, obviously, and if the respiratory distress is persisting, you may get cyanosis in severe cases. So this is what is the epiglottis looks like in acute epiglottitis. The left one is normal, and this is the red swollen mass is epiglottis. Okay, and there is also surrounding larynx and pharynx are also congested and swollen. The anatomy is already disturbed. Okay, child will have very much difficulty during breathing. Okay. So what is the investigation? As it is a very emergency case, you will have to admit the child, you will have to draw the blood sample and send for blood culture, and you will have to do a X-ray. See the X-ray. This is very characteristic. This arrow, this indicates a sign which is known as thumb sign. Okay, remember this. It may come as a MCQ in any exam in your future. So what is the treatment? It's an emergency, so you will have to admit the child, you'll secure the airway, give the oxygen, and you will have to give the child IV fluid to maintain the hydration. The specific management is to give IV antibiotic because it is a bacterial infection, not viral. So you will have to give antibiotic. Which antibiotic? Either cefotaxime or ceftriaxone, 100 milligram per kg per day for 7 to 10 days. And if the obstruction is so severe, the child is not able to breathe, in such severe cases, we need intubation. Okay. So any question regarding acute epiglottitis? So no. Dose 100 milligram per kg per day. Okay, so move on to the next topic, acute epiglottitis, acute laryngotracheobronchitis. Okay. Acute laryngobronchitis, also known as Croup. Okay. This is very common. Okay. Honestly speaking, I have never seen a case of acute epiglottitis so far because the introduction of H-influenza vaccine, okay, has already declined the cases of acute epiglottitis. But this is common. This is viral infection. Okay, this is a viral infection and it is common. It is seen today's. Nowadays it is seen very often. Okay, so listen carefully. This is commonly seen in the age group of 6 months to 3 years. The previous one was commonest age group was 3 to 6 years, but this one is 6 months to 3 years. And the causative organism is para-influenza virus. Type 1, 2, 3, 4, but type 1, 2, 3, but type 1 is the commonest, okay? And spread through either direct inhalation from a cough and or sneeze or by contamination of hands. And it's most likely to occur during winter and early spring. How does the sound of Croup occurs? Again, this is due to narrowing or obstruction of the airway, okay? Inhalation of the virus through nose or nasopharynx, this causes respiratory epithelium becomes inflamed and edematous, okay? This is normal larynx, this is the inflamed larynx. There is airway narrowing, airflow through the airway becomes turbulent, okay? And it causes the stridor. So clinical features, as this is a viral infection, we will get some prodromal symptoms like rhinorrhea, sore throat or cough. There may be fever, but the fever is not very high grade, low grade fever. You will get hoarseness of voice, barking cough, also known as Seal's cough. Okay, barking cough. Stridor. Here the stridor will be inspiratory, expiratory, or biphasic. Biphasic. Laryngotracheobronchitis, not above the glottis. Okay. Biphasic stridor. So this sign is also very much characteristic of ALTB, that is subglottic narrowing, which is known as this one. You can show there is narrowing of the subglottic structure. So this is known as Steeple sign. Okay, Steeple sign. So remember the two signs. Thumb sign is for acute epiglottitis and Steeple sign for ALTB. Okay. How will manage the case? It may be mild or moderate to severe. If the ALTB is mild, then the treatment is not so aggressive. You will just have to reassure the parents, give IV fluids, give more fluids at home, and you will also educate the child when to come back. Okay, if the disease progresses further, you will have to bring back the child to the hospital and need hospitalization. But if initially the child presents with severe type of respiratory distress due to ALTB, then we will have to manage it aggressively and have to admit the child. So again, you will have to do the ABC, that is airway, breathing, circulation, maintenance, give oxygen, give IV fluids, etc. Epinephrine nebulization, 1 in 10,000 solution, 0.1 to 0.5 ml per kg, maximum 5 ml, is very much effective to relieve the immediate symptoms. And dexamethasone, single dose of dexamethasone, 0.6 milligram per kg intramuscular. It is a dramatic role in case of ALTB. Okay. Then budesonide nebulization, 1 milligram twice daily for 2 days, give some relief. Okay. If the above medical treatment fails, then we need a short-term ventilation. So these are the difference of the acute epiglottitis and acute laryngotracheobronchitis. All points I have already discussed. Just look. The appearance will be toxic and annoying in case of epiglottitis because it is a bacterial infection caused by H. influenzae type B virus. And in case of ALTB, the looks will be well because it is a viral infection by parainfluenza type 1 virus. The onset will be abrupt onset in case of epiglottitis, but the Croup, in case of Croup, it will be gradual onset with some prodromal symptoms like rhinorrhea, cough, etc. In case of ALTB, there will be high-grade fever with toxic look in case of epiglottitis, but there will be moderate fever in case of ALTB. Stridor is usually moderate to severe in case of epiglottitis, but usually mild to moderate in case of Croup. The cough is minimal or absent in case of epiglottitis. Remember, any case of bacterial infection does not give so much cough, but if the cause is due to some virus, there will be the cough will be extensive. So barking or seal-like quality of cough is seen in case of heard in case of Croup. The child will be unable to speak in case of epiglottitis, but there is only hoarseness of voice. Can't speak, but there is hoarseness of voice in case of Croup. The child will be unable to swallow, or there will be drooling of saliva in case of epiglottitis, but child will be able to swallow in case of Croup. Next come to the last part of the today's discussion, that is foreign body aspiration. It is one of the also commonest cause of acute stridor. Acute. Any child, he was absolutely well and rushed to the emergency of your hospital with some respiratory distress, and there is stridor. Okay. If the child is having acute onset of respiratory distress with stridor, always think of any type of foreign body aspiration. Okay. Never think other congenital causes like Laryngomalacia or other which was discussed previously. So always think of stridor because this is very common, particularly if the child is between this age group, that is 6 months to 3 years. Okay, why this age group is so much common for foreign body aspiration? Because you can easily remember that in this age group, the childs have always a tendency to give any type of maybe any food or any material to put into their mouth. And also they always speak while they are giving feeds. They do not swallow, they actually swallow but don't masticate, poor mastication. All this causes these children to have their food particle or any type of material into their mouth and causing obstruction into the airway. The site where the foreign body gets lodged depends on the size and nature of the foreign body. It may be any type of food particle or non-food particle, but remember the most common cause is any type of food particle. The acute presentation will be like cough, with cough, respiratory distress and blood-stained sputum. Rest of the symptoms depends where the foreign body is present, where the foreign body gets obstructed. If it is in the larynx, the child will present with hoarseness, whooping cough, apnea, hemoptysis, dyspnea and wheezing, and in severe cases cyanosis. If the foreign body is in the trachea, there will be persistent cough and the child is present with wheeze, just like asthma. If the foreign body is more deeper, that is into the bronchi, there will be recurrent pneumonia, lung abscess, hemoptysis, focal bronchiectasis. So these are the very advanced cases. And there you will get diminished air entry on examination, unilateral wheeze, limited lung expansion and impaired percussion note on the affected side. And if we do an X-ray, remember in almost 80% of the cases of the laryngotracheal foreign body, the X-ray is normal, and 15 to 25% cases of bronchial foreign body, the X-ray is normal. So X-ray is not only a normal X-ray doesn't mean that there is no foreign body. Okay, so X-ray may be normal. Okay, but if there is some findings, what are the findings? You can see there is a foreign body, there is a screw. Okay, in the right, left main bronchus. And there will be initially air trapping, mediastinal shifting, atelectasis, and finally there will be some consolidation or collapse. And foreign body can be visualized by X-ray if it is only radiopaque. If it is vegetable foreign body, it is not visible in the X-ray. Okay, and for this you will need fluoroscopy for radiolucent foreign body. Okay, And bronchoscopy or laryngoscopy is very much effective both as diagnostic and therapeutic. And lastly, you can do a CT scan where there may be it shows the object and may identify the localized ear trapping. The CT scan showing a foreign body here. Here, this is the foreign body. So what are the treatment options? That is Heimlich's maneuver. I will show it details in the next slide. And laryngoscopy or bronchoscopy will also help to, as already mentioned, both diagnostic and therapeutic purpose. Flexible laryngoscopy or bronchoscopy is done under the LA, local anesthesia, and rigid laryngoscopy done under the GA. All these are actually part of the ENT surgeon. I'm just mentioning the treatment options, okay? And open thoracotomy is needed if the foreign body is impacted in the deep part. This is, you should know, Heimlich's maneuver, how the maneuver is performed. So if it is a very younger child, that is infant, the infant, you just place the infant under your, place the infant stomach down across your forearm and give 5 thumbs on the infant's back with heel of your hand, okay? And if it is older child, if it is a older child, just put your hands, make a fist, okay, like this one, and this fist here, just above the stomach, and the thrust should be inward and backward, okay? So inward and backward thrust. Just stand behind the child, make a fist, and give the pressure just above the stomach, inward and backward. So this is done in case of infants, okay, 5 thumbs, and this is done in case of older children, okay. And this is laryngoscopy or bronchoscopy. This is done, the patient lies in supine position with the neck flexed on an extended head, which is known as barking dog position. This is done, laryngoscopy or bronchoscopy is done like this one. This is actually done by the ENT surgeon. I have no practical idea, just giving some theoretical idea to you, okay. So this is all about today's class. Okay. As usual, I always like to ask some question. দেখি কেমন ভালো করে শুনলে তোমরা। কোশ্চেন করে যাবে তো? বলো। সবাইকে জিজ্ঞাসা করব। এক এক করে জিজ্ঞাসা করি, হ্যাঁ? বলো। আগে ওঠো, তারপর বল। তুই বল। তুই ওঠ। বল। এই ইজি কোশ্চেন, ভেরি ইজি কোশ্চেন। ওঠ না। বল। উঠে দাঁড়া। স্ট্যান্ড আপ। ভেরি গুড, লারিঙ্গোমালাসিয়া। তুই বল। Laryngomalacia, very good. ঠিক আছে, ভালো বলেছ। আচ্ছা, বল তুই বল। হ্যাঁ, বসে যা। বল তুই বল। ওঠ, স্ট্যান্ড আপ। ইজি কোশ্চেন। বল। বল, কোশ্চেনটা জোরে বল।
Most common causative organism for ALTB is
ALTB মানে he is asking what is ALTB. Okay. Acute Laryngotracheobronchitis. বহুবার বললাম তো ক্লাস চলাকালীন। ALTB কি বলবে? প্যারা ইনফ্লুয়েঞ্জা ভাইরাস। আমাকে জিজ্ঞাসা করলো হোয়াট ইজ ALTB। ঠিক আছে, ওকে, থ্যাংক ইউ। ALTB হলো, হ্যাঁ, Laryngomalacia, হ্যাঁ হ্যাঁ হ্যাঁ, Laryngomalacia তো মোর দ্যান 70% অফ কেসেস। বল তুই বল, স্ট্যান্ড আপ। বস বল, বলো বলো, নেম দা রেডিওলজিক্যাল সাইন। না, কেউ বলিস না, বলিস। হ্যাঁ, স্টিপল সাইন। হ্যাঁ, থামস, এটা ভালো শুনেছি, ঠিক আছে, থাম সাইন। থাম সাইন দেখে তো থামের মতো লাগছে না? ইট লুকস লাইক থাম সাইন। আচ্ছা, বলো, হোমাকাস এপিগ্লটিস বলো। হ্যাঁ, কিছু পাওয়া যায়? হ্যাঁ, সেকেন্ড ওয়ান। হ্যাঁ, স্যার বলো, ওটা কি স্যার? তো সবই বলে দিল।